one of the highlights of our academic year is, the named lectureships that we have. We have several very, very important ones. The original plan for today, which, as you know, was enhanced and modified, is the Peter Jannetta lectureship, which is what's going to be delivered right now. We'll have a couple of our faculty members say a few words. Before that, I want to recognize Jannetta for visiting with us. I remember very well, the time that Peter was here with us for the lectureship, and he gave a beautiful lecture. It was very, very nice. He lives in our hearts, and he's here walking in his department every day. And we see his picture all the time. So he was obviously an icon and a giant in the surgery. And more words will be said about that. As you all know, we're going to have a part 2 to this event at the Pittsburgh Golf Club, the Dorothy Klenke Nash lectureship, and that will be a little later on. I also want to welcome our friends and alumni that are joining us by teams. We're delighted that you're able to be with us in this important day. Our Peter Jannetta lecturer is Dr. Martina Stipler, former alum from our program, doing amazing work in organized neurosurgery, as well as in Boston, where she's a faculty member at the Israel Hospital currently. To kick this off, I'd like to ask Dr. Maroon first to say a few words about Dr. Jannetta.
Thank you. Chair?
I think so, yeah.
Yeah, okay, very, very good. Thank you so much, Robert. It's a great pleasure, Diane, to have you here with us today. 50 years ago, Peter J. Jannetta came to the University of Pittsburgh to inaugurate the first Department of Neurosurgery here at UPMC, here at the university. And since then, he's trained 49 residents, 6 chairmen of departments, and 2 pediatric chairs. And 5 years ago, when we initiated the Peter J. Jannetta lectureship, Mark McLaughlin, 1998 graduate of our program, put words out that Peter would have said himself. And I would like to read those to you. Peter said, "The true joy in life is being used for a purpose recognized by yourself as a mighty one, being a force of nature instead of a feverish, selfish little clot of ailments and grievances, complaining that the world will not devote itself to making you happy. I am of the opinion," said Peter, "that my life belongs to the whole community. And as long as I live, it is my privilege to do for it whatever I can. I want to be thoroughly used up when I die. I want to be thoroughly used up when I die. For the harder I work, the more I live. I rejoice in life for its own sake. Life is no brief candle for me. It is a sort of splendid torch, which I have hold of for the moment. I want to make it burn as brightly as possible before handing it off to future generations." And Peter initiated the culture that still really permeates virtually everything we do in this department. And what is that culture, that attitude, values, goals, and practices that make up the culture of the University of Pittsburgh Department of Neurosurgery? And that culture begins, as Peter emphasized, the pursuit of excellence in everything we do to better patient care. Excellence and innovation. One of his favorite books was by Thomas Kuhn, the Structure of Scientific Revolution. And Peter was an iconoclast. He looked for paradigm shifts. He emphasized that in all of the trainings. And along those lines, in 1985, a young, long-haired, mustachioed resident came to the department, 75, wasn't it, Dave? In 75. And one of the very first residents that he recruited. And iconoclastically, after Dade won the Van Wagenen Scholarship and came back, and he importuned Peter, we need a gamma knife here in Pittsburgh, the first in the United States. Very well supported, instituted, 18,000, 20,000 patients later, complete paradigm shift in how acoustics, AVMs, pituitary tumors are handled. Subsequently, he encouraged me to work on skull-based surgery with Gene Myers, the head of ENT, and also Jack Kennerdell in orbital surgery. We operated on over 1,000 orbital tumor patients, and really another shift that is carried on by Paul Gardner and Carl Schneiderman now. And then in endovascular, Brad Gross and Mike Lang, again, a paradigm shift in how aneurysms and vascular things are treated. And now we come to another iconoclastic individual, Martina Stipler, who, because of her incredible work in talking about inclusivity in neurosurgery and also burnout and moral distress in neurosurgeons, was earned the appointment of secretary to the Congress of Neurological Surgery, and if all goes well, I think it will, she'll be the third president of the Congress of Neurological Surgeons trained here at the University of Pittsburgh. So with that, I will introduce Dade, I think, who's going to introduce Martina.
Well, we're going to have to give time at the end for Martina to talk, I think.
So Dave, please go ahead. And
So, when I resident graduates, I go through all the stuff that we chronicles related to their behavior and their importance to the department over the years. So this is now about 20 years. So, in 2002, Martina had come from Innsbruck, where she was trained and gotten her medical degree at the Leopold Franzens University. She came to the United States with a suitcase, or maybe two suitcases, and she got her internship organized at the oldest hospital in the United States, the Pennsylvania Hospital. And then we got a call, Doug Cantioca and I, you know what, this is a really outstanding person, and the most important thing that they could say is, well, we don't have a position, we'd take her if we could. And so we had Martina come as a PGY2 resident at that time. A year later, she had already gotten a plenary talk at the AANS meeting and the Louise Eisenhardt Award at that time. And of course, she continued on all that time. A few years later, she got her master's degree here while a resident working with Ed Dixon. And after she finished, now 10 years ago, she gets ABNS certified. She moves from New Mexico to one of these Crimson affiliated institutions in Boston. And we exported somebody really good to Harvard. And for Harvard, they don't normally go outside of their comfort zone. So that's a huge achievement. So when I go back and look at what people write, sometimes you try to look for certain words to describe a person. And among those that came out in her reviews was the word tenacious, vivacious, energetic, wonderful personality. And eventually somebody wrote, she's a jewel in our department of Crown. And it probably doesn't get much better than that. The only issue that I recall with Martina was, and I must confess I shared this problem, she had abominable handwriting. And until computers really came into their forefront and everything was data entry, no matter what was written, she could tell you whatever she wanted it to mean. And it was basically totally illegible. So it's wonderful now, 20 years later, to have you back in this position, in this distinguished lectureship here as a visiting professor. And it's great to see you. If anybody's been able to make her life perfect with children and a home and a family and a career and things like that, Martina's a great example to look forward. We look forward to your talk today.
Thank you. Thank you very much for the kind words and the introduction. I was a little bit worried what will come up there when we go back to my residency. It's a distinct honor to be here today. I really enjoyed meeting with the residents and giving you my talk today about triage and the management of complicated mild traumatic brain injury. I think I want the residents to pay attention, of course, to the content of the talk, but I also really want to look a little bit how I developed this research idea, because sometimes the smallest ideas or the pain points you find in your residence, in your practice, really can set up a research project and can be then your academic path. So pay a little bit attention to that as well. So I will talk a little bit about the natural history of complicated traumatic brain injury and really what it means and define that for you. And talk about two projects over my academic career, which I implemented and tested in these environments. So when I talk about complicated mild traumatic brain injury, I considered a GCS score of 13, 14, 15. There's abnormal head CT, and there's no focal deficit. This patient doesn't have a drift or a weakness that can be contributed to abnormal head CT. And most important at all, they would not need surgery. So this is not a subdural hematoma that I'm looking at the scan and I just think it's big enough, or there is this depressed skull fracture that I would take this patient to the operating room. Okay, so the first question, and maybe I can do this here as well. So the first question that I want you to answer is it my practice to return uniform head CTs in these patients that have mild traumatic brain injury?
Martina, can I ask you to define, when you say abnormal CT, but there's nothing to operate on, so what specifically on the CT might?
So trauma related. So subarachnoid hemorrhage, it could be an epidural hematoma that when you look at it wouldn't consider
anything that doesn't go to the OR.
It can be a contusion, it can be a skull fracture, subarachnoid hemorrhage, contusion, subdural hematoma. Okay, so when it gives this projection software, it's sometimes really hard for that to come through, so I will share the results with you this way. So most of the time, 57% of you say most of the time you will perform it. Rarely, 27% of the time, not at all, 13%, and it's not my scope of practice to perform any head CTs. Let's go to the next questions. How often have you, after you got that CT scan, the follow-up CT scan, okay? So you have this patient, you decide that you're not gonna operate on this patient, you get your routine follow-up CT scan. How often have you changed your management? So we had about 57% of you guys that we're getting a scan. So how often have you ever changed your management? So the results are, and you're just gonna have to trust me on this, that I'm giving you the right results, okay? Never 18%, rarely 65%, and about less than 21% said about often more than 10 times a year they have changed their management. Next question. So we're gonna make this discussion a little bit like a debate, all right? So the notion, which I'm gonna convince you, I have about 45 minutes to convince you, and I know you have been indoctrinated with Dr. Okonkwo, who is not here today, for me to counteract here, have you offer myself. So I want to say, my notion is routine follow-up head CT is not needed in the majority of complicated mild traumatic brain injury patients. And I say, and then for this, so we have 64%, as I said, it's going back and forth, 71% would agree with me that we don't need head CTs, and about 30% said we need them. And to really have a debate here, I wonder if you're open. Do we have like a debate? Are people open to change their mind on this one? Good, I like that. 80% have an open mind here. All right, I think we have a real debate going here. let's back up a little bit based on traumatic brain injury patients. 2.8 million people sustain a traumatic brain injury annually. 2.5 million people are treated in the emergency department. A smaller portion is hospitalized, and then you can see still a significant amount of death. The overall estimated financial burden is 76 billion. I was told that it's a mission to the Mars back. Let's look at these trends. I think these trends are really eye-opening, as you can see how their hospitalizations and ND visits have increased over time. You probably asked that this is very old data, but these are CDC data, and it takes them a while to put it in their system. And I checked before I gave this talk to see if they have any new data available in their database. But as you can see here, the hospitalization and ED visits kind of skyrocketed versus deaths kind of stayed same in hospitalization. But we have much more TBI and we have much more ED visits. And probably every resident in the room can sing a song about this and know how much often we get called down in the ED. So where do these patients come from? Do we have more traumatic brain injury? Do we have more motor vehicle crashes, more assaults? What's going on? And I think, again, this data show it very clearly, unintentional falls. So we have a high rate of unintentional falls. Again, the elderly patients that end up in the emergency room and that we can see. Okay, so let's go to a patient scenario. So you have a patient, 51-year-old male, G615, fell off his Peloton bike. He has no neurological deficits. What are we gonna do? Are we gonna get, they had a small traumatic subdural hemorrhage in series 2, slice 16. Are we gonna get a follow-up PET CT in this patient? Would you get a follow-up PET CT in this patient?
Are you waiting for an answer, Martina?
Oh, I'm doing polling. See, it's so nice to see you.
Do you need the QR code?
No, I don't think I have the answer right here. Okay.
Well, no, you have an answer. The answer is
John, she could read our minds.
well, I don't doubt that she can in some respects, but practically speaking, I didn't know you were doing a computer.
Yeah, I was doing the polling, and it was a screen capture. It doesn't show, but it shows up here. Okay, so we have 47% of you guys would get a head CT, and I really like to see that 53%. Is that how you practice here? No, I.
Now they get 2 of them.
Huh?
4 to 6 hours and 1 in 24.
And an MRI, so we have it.
Okay. Okay, so 50-50. So what would you do with the patient? Are you discharge him to home? Are you going to admit him? You're going to observe him in ED? Or I gave you an opt-out here for not sure. You know, which is very interesting, because it shows up here, the poll, but it doesn't show up here. I wonder if we are sharing, I don't know. So we have discharge to home, 6%, admit to the hospital, 56%, and observe in emergency room for 33%. So I can tell you a little bit about what we are doing in this patient. So when you look at this patient, a typical traumatic subdural hemorrhage patient that has a non-neurofocal exam, has a minor injury. If you take these patients, less than 10% of these patients actually have a positive CT scan. That's the one we get called on, right? Blood in the head, or at least on the read. Who knows if there's actually blood in the head, but at least it's read this way. And if you then really look, and this is based on the first CT scan, less than 1% of these patients need a neurosurgical intervention. But we going even a layer beyond that because we are looking at the second CT scan. I'm not talking about getting that first CT scan. We have rules for that, when to get a first CT scan or not, and mostly emergency medicine makes the decision for us. And I'm also not talking about the patient that has a GCS of 14, has a lucid interval, and a 2-centimeter epidural hematoma. I'm talking about the patient that you think should not have a follow-up CT scan. So what would we have done with this patient? I just showed you. We would have not gotten a CT scan, and we would have enrolled him in ED ops. So let's tell me a little bit about our ED observation protocol. So our hospital was losing money because we were admitting these patients to the ICU and sometimes to the step-down unit. And they looked at ways of observing this patient in an emergency room. And this is the protocol we came up together with our emergency room colleagues, emergency department colleagues. We decided that you need to have a GCS of 15 and 14, that you need to have a CT scan positive for traumatic brain injury, traumatic subdural hemorrhage, subdural hematoma less than a centimeter, and then contusion without midline shift. Needs to be an isolated injury. What people did we exclude for being kept down in the ED ops? So if they had multiple traumas, if the GCS was 13 or below, if they had an epidural hematoma, just because that we know people can expand rapidly, and they need to be observed closer. Skull fractures with intercranial hemorrhage. We didn't want to miss a delayed epidural hematoma. Post-traumatic seizures, because it's just sometimes hard to examine these patients and do a neuro exam. And patients that were in any form of anticoagulation, antiplatelets would be excluded, aspirin. And of course, we gave the emergency room kind of out to decide if they just didn't feel comfortable. So we did this for a couple of years, and then we published our results, and that you can kind of see what came of it. So we enrolled 209 patients, and you can see the exclusion criteria that we had. But overall, we could 138 patients were kept in our ED ops. What was a real surprise finding, and I'm curious if you have the same issue here, or I don't know if these patients go to Mercy, is that we found 80% of these patients were actually transferred from other hospitals, from our network, to our main trauma center. So 80% of the patients came from somewhere else, and that kind of led to the third project I'm doing right now, and we'll talk about. Because we are now doing teleradiology to keep these patients actually where they started out. Because we sent them to neurosurgery department, and we just sent them home. So that was a very surprise finding for us. So we looked at the patients that were discharged. We see how long they stayed in the hospital. None of them required neurosurgical intervention, and we kind of looked at our outcome and representation to see if we missed anyone. Let's just keep them then ED ops. I have to say that initially when we rolled this out, we still did our follow-up PET CTs, and we went down 12 hours later and wrote a sign-off note. And the pandemic was a real good catalyst, because we actually starting for these kind of consult doing in-house teleconsultations. We wanted to minimize the exposure of our residents and APPs to go down to the emergency room. And we kind of faded away from the emergency room, and we told them, listen, we have done this for 2 years. If the patient deteriorated, you called us. Most of the time you already had a second head CT. So there was really no added benefit to show up 12 hours later. And we are just, admitting the patient to ED ops, and they stay there for 6 hours. Okay, let's go back. So I'm gonna pivot now. So we did this, we had good outcomes. And then the next part, it's like, if a frog is in the water and if you throw him in boiling water, he jumps out right away. So we didn't want this to do with the emergency room. So we just dialed up the temperature, right? First we did ED ops, then we didn't come back for the 12-hour visit. And the next temperature was not to get a follow-up PET CT, okay? So the question is here for you guys, what are some of the reasons that you get a follow-up PET CT? Enlarging subdural hematoma, because you think it's enlarging. Mass effect, interval expansion, legal, fear for Dr. Okonkwo, or fear that the patient is doing this? Blossoming and contusion, backup for resident exam. So let me unpack. Attendings, don't yell at me. Exchange, shame, worsening headache. So let me unpack this a little bit. So, and I will show you that protocol that we used. Of course, if there's a neurological change, of course you will do a second head CT. Worsening, expanding subdural hematoma, mass effect. Well, if a patient has a non-focal exam, GCS of 15, and you don't think that a subdural is operated the first time, a follow-up head CT will still show the mass effect, but we're treating the patients, we're not treating the skin. I will show you data that about 20% of any contusion, any subaround hemorrhage will have a radiographic increase. So there will be a blossoming of contusion, but that is radiographically. And I asked you this question before, how often did you make any changes? And more than 70% of you reported, very rarely do you make a clinical change based on this follow-up head CT. Legal, I think it's dogma. I love that. This is like, I wanted you to write this. Okay, so dogma, right? So I think there's a real responsibility for us to, the way we treat patients and the way we do medicine, move along with the advances, and especially the advance in imaging, and I will talk about this. And we also need to train the next generation of neurosurgeon or the emergency room physician and acute care physicians who feel okay of treating these patients and keeping these patients in the emergency room. This goes back to dogma, right? So this is the first head CT that was obtained to calculate one slice took 4 hours. I dare you to find a traumatic subdural hemorrhage on that CT scan, right? This is how CT scans, the quality of a CT scan looks now. So our imaging quality over the last 50 years has significantly improved to make diagnosis of clinically very insignificant findings like a small traumatic subdural hemorrhage. But we're still practicing. We're still stuck in our old dogma of getting a follow-up head CT. So I want to challenge you today. Let's, as the medicine, as imaging technology changes and advances, let's also adapt the way we treat patients and have a different change our algorithm. It's an absolute change the way patients have been treated before, and it needs to be done in a collaborative and multidisciplinary approach. But we were able to do this in our institution. And I like this picture here where you just can see how the CT scan quality changed over time as they were following patients for subdural hematoma. So how did I get started on this topic, and why did I choose this topic? So my first job was in the University of New Mexico. We were the only level 1 trauma center in that state. And most patients, if they were injured far away, it was a fixed wing transport. So they had to go on a plane. It took them hours to get here. And by the time they came to my emergency room, it was out of the 6 and 12-hour window to actually get a follow-up CT scan. Most of them were wrongly diagnosed in the first place. And we said, well, yeah, you're fine. You can go back home. And they said, well, I spent all this time to get here. Most of them were social economic barriers. The family said, well, we don't have money for the gas to pick him up and pick up this patient up. So I'm like, there's a lot of the service we're doing for these patients. Can we do this better? So I started looking at literature that was published, and people, especially from in Europe, have done work in that space and really said, if there's no clinical deterioration, if you get the head CT not based on a clinical deterioration, very rarely does it lead to intervention and a change in care. Then my next step was, let's do systematic review. So we looked at all the literature, put all the cases together, and what we found, again, we found the 20% of radiographic progression. We found that the time between the first and second scan, but when the first scan was 2 hours after injury, and the second scan was about 21 hours after injury. And again, our meta-analysis showed if there is no asymptomatic head CT, definitely predict neurosurgical intervention, and asymptomatic head CT did not. So I said, well, this is a meta-analysis, or this is retrospective chart review. Let's do it prospectively. So we looked in our perspective on these patients that we enrolled in our database and looked like which patients that I didn't think needed a surgery ended up getting a surgery based on the second head CT. There's definitely, so if you look at the right side, there are no epidural hematomas in there because there's definitely selection bias, right? We are much more aggressive on operating epidural hematomas. And we found that most of the time there were the subdural hematomas is that they needed surgery. And especially we talked about, we reviewed great cases today, chronic subdural hematomas, acute and chronic subdural hematomas. Sometimes it takes you a day or two to figure out that you want to do surgery in these patients. So I think at this point, I wanted to move to the next step and really implement that program. I thought I had the evidence that we are moving away from the second head CT. So I'm not the first one who's doing this work. Dr. Joseph et al. Dr. Joseph is acute care surgeon in Arizona, and he developed the big protocol, brain injury guidelines. He divides them in 3 groups. You can see, if you look at these cutoffs and parameters and not parameters we typically use in neurosurgery, but he did work in that space. And if you're in the big 1 category, you don't get repeat head CT, and you also don't get a neurosurgical consultation. If you fall in the second category, you are hospitalized, you don't get a repeat head CT, you don't get a neurosurgical consultation. And if you're in the 3rd category, you get all 3. I'm not there yet that we as neurosurgeons shouldn't own these patients. I think there's definitely the space we don't want to give up. But I'm totally speaking from an area of privilege because I have all my residents who see these patients, right? I don't have to get up in the middle of the night and see these patients. We know there's a shortage in neurosurgery workforce. There's a distribution to bigger cities, and there's underserved areas in neurosurgery in rural areas. So if we have a neurosurgeon in the rural area, do we really want to overwork him and then give up his cranial privileges and not take trauma call anymore because we call him about every little small subarachnoid hemorrhage? So I think in academic centers may be practiced a little bit different than, but we have to think about our specialty overall. So these are the data about Joseph et al. Did. You can see by the severity of traumatic brain injury, we don't really want to change severe traumatic brain injury. They need to develop CT scans, and I would argue moderates as well. But it definitely decreased the number of CT scans he got in mild traumatic brain injury and also the number of neurosurgical consultations. In his initial study, he still included aspirin. So aspirin immediately triggered to a CT scan, and then people in community did the study again and excluded aspirin of that you can forgo a follow-up PET CT because otherwise you would very, very hard to really find a patient that you can use this on. Okay, so now we have another patient here. 78-year-old, fell downstairs, aches and pains from the fall, GCS 15, no neurological deficit, and we have that CT scan here. How would you treat this patient? Discharge to home, admit to the hospital, observe in the ED, and not sure. So we have a 94% admitted patient in the hospital, small percent, now we have to 12% observe these patients in the emergency room. So if you measure the subdural hematoma, and then would you get a routine follow-up CT scan of this patient? And most of you guys would, 94%. And if you measure the subdural hematoma, it was bigger than a centimeter. So you see the different patients, right? You have the patient on the right with the small traumatic subdural hemorrhage, and you have at about a centimeter subdural hematoma on the left. So this is our protocol that we have used at the BIDMC now, for 5 years. So we have been using this for 5 years. And over the last year, we also rolled out this protocol to our peripheral hospitals that do not have neurosurgery so we have a telehealth system in place where we triage these patients. So let's walk through this algorithm. So GCS 13, 14, 15, no, you get repeat head CT. If you fall in that category, is the patient an anticoagulation, antiplatelets other than aspirin? If no, we go down further. Is this an epidural hematoma, or is there a subdural hematoma greater than a centimeter? If the patient has anything else, then he will not get a repeat head CT. We admit this patient to ED ops. We observe them for 6 hours, and then the patient will discharge to home. Depending on what the patient is, they maybe follow up with our concussion clinic, or maybe they follow up with us.
Who's reading the scan in the outside hospital?
So in the outside hospital, so I look at the scan. So most of them, they have their own radiology read it, and then he reads possible image, series 2 imagery, possible small hypertensity, cannot rule out traumatic summer hemorrhage. Then that triggers, then they look at all these parameters, and then that triggers for them to call me. And then I have access and I look at the images. And then they decide either I agree that this is a subdural hematoma or contusion, and then they ops the patient there. And if I say, no, this is actually a negative CT scan, they will discharge the patient, or say, no, the patient needs to be transferred. Anybody in any form of anticoagulation is automatically transferred.
Can you go back to that criteria again? Are you able to?
Yeah.
1, 2 slide?
I can tell you, okay, let me just take a.
Or you don't have to.
Yeah.
Maybe I read it wrong, but a 20-year-old football player gets a 9mm subdural with a GCS of 14, does not get the follow-up, and no.
We observe him, but no, he would not get a follow-up CT scan.
Would you let him go back to playing football?
that's like if your kid had a 9mm subdural and didn't know where he was, but knew his name, and you'd be okay with taking him home in 23 hours without follow-up CT?
So, I mean, if you have no neurological change, I mean, if the patient changes neurologically, right?
I'll say he still doesn't know where he is the next day.
We probably would admit him, but we would not get a follow-up CT scan.
Well, I'm just saying, according to that criteria, though.
That is, yeah, this is following this criteria. He would not qualify for follow-up CT scan.
Oh, but he would qualify for admittance, but not.
Yeah, I mean, I think that, yeah, sometimes we admit this patient, sometimes we ops them. Yeah.
I think if you're considering the medical legal implications of what you're doing as well.
Yeah.
So you find that's very defensible if they have a subsequent 9mm hematoma and they deteriorate rather quickly, even under observation or 2 or 3 days later. You're not, you obviously.
Yeah, so we have the data. So we studied this, we have the data. So for example, all the patients we admitted, right? So we looked at all the patients where our spider sense was going up, or the patients that had acute, anticoagulation, where we said we need to admit them. Not a single one of them progressed to surgery. Not a single, because it's not the patient that where you look at the CT scan and said, I need to do operation on this, right? But I would argue that you have a 9mm subdural hematoma in a 14-year-old, you maybe do surgery on them. Another 21-year-old football player, if he has full brain, because he might get in trouble. He may be more than just oriented, have a decrease in orientation. I might argue that you have but I would, I think if you have a full brain, you maybe get in trouble from a 9mm subdural hematoma and and maybe you would take him to the OR instead.
So the point being that the neurologic exam would reflect the size of that hematoma, and that maybe the scenario,
I understand.
Scenario is not even realistic.
Yeah, well, okay, make it a 50-year. I mean, I guess what I'm just trying to get at is that when you look at this in the whole, in the population, the society, like this is New Zealand. These are I guess it's just different here.
What you're trying to get at
and what we're trying to do is, are we trying to emulate them? Because I remember David did this, right, with cervical, with people getting taking them out of collars.
Yep.
And it's like, how many people do you have to get negative scans on before we say, well, how many subdurals is it okay to miss expansion before we say, is it okay to have 1,000, 10,000?
Very good point. So go back to Dr. Maroon, so medical legally, right? So this is our standard of care in our hospital system is something to stand on. I know that the MGH adopted the same. Now it would be great if we could roll it out. Because in medical legal cases, it's always what's the standard of care in your area, right? If we could get all the hospitals. The MGH adopted the policy now. If we can get BMC and other hospitals on there, I think that would be the next step. But I think our data are great. And coming back to you, right? Yes. So this is 300 people there. I'm doing it for 5 years. We have the outcome data on the patients, even the ones that we thought that would get in trouble, never needed, another surgery. Is that the lowest denominator? That's what I care about. Do I miss, an operative intervention? But I think the next step is really to do this big scale, right? To do this in multi-center, have people feel comfortable adapting this protocol and get to the thousands or 10,000s, and then maybe even do it with big data of trying to figure out exactly who is going to deteriorate and who won't.
How about the patient with the 5 millimeter, whatever, less than 1 centimeter subdural, observe him, you send them home, and you said follow up in concussion clinic. Is that with an MD or that's a?
Yeah. So this is so if they, for example, have a 5 millimeter acute subdural hematoma, I have them follow up with me with a neurosurgeon because I'm worried about developing a chronic subdural hematoma.
So they have a headache at that point. Do you get a scan?
So I scan them in follow up. Yeah, in 2 weeks they would get
Follow up.
because I'm worried about the chronic subdural hematoma. But if they have a small traumatic subdural hemorrhage, so in the beginning we have an excellent concussion clinic staffed by neurologist, board certified in brain in rehab medicine and traumatic brain injury, and she runs the concussion clinic. And initially we booked all these patients in there, like automatically they got an appointment. And they had all these no-shows because the patients just felt better and didn't want to go in. We looked, they didn't all die. And so now we offer it to them. But I, for example, had a patient through that protocol that ended up diagnosing with MS. So I have a very low threshold. Like that doesn't look right. Yes, you fell. Come into my clinic. Let me follow up and see if you need additional imaging. But if there is a small traumatic subdural hemorrhage, we offer them the concussion clinic.
What about home conditions or who the patient lives with? Does that go into your equation? Like if they live at home by themselves and they have a small subdural or?
Yeah, so we follow the same standard. Like there's we do with concussion, right? When you get discharged from with a concussion, they say you need to be under supervision. They need to wake you up every certain amount of hours. So we give them the same instructions. Yes. I asked the other question, how comfortable would you be practicing with this protocol? 40% said, I'm not sure about this, and 60% said, yes, I'm on board, no problem for me. I like that. I'm happy with that result, and I'm not lying. I have it here, the results. So this is our patients, right? So these are the patients. We looked at the data for a year. So we had 178 patients that we enrolled. You could see the age. These are elderly patients. Male, female, equally distributed. These are falls. One of my first slides really was how just most of the traumatic brain injury patients we see now are because of falls. So this is the increase, and that's what we see reflected here. Median GC is 15, and then you can see that a majority of patient is on antiplatelet or anticoagulation, and these patients cannot be included. So you can see how we flow through our diagram. So initially we looked at our criteria and our path and said 84% should not get a follow-up PET CT. You're going through this triage algorithm. And then 15%, 27 said you getting a follow-up PET CT because you have an epidural, because of the size of the concussion, because of the size of the subdural hematoma, and because of your anticoagulation. So these patients, by clinical judgment, were yeah, you need a follow-up CT scan. So of the 151 where we said we do not want you to have a follow-up CT scan, actually 126, 70% actually got no follow-up CT scan because we stick to our own guns. There were violations. You can see 17% of either, it was actually most my neurosurgical faculty, ER and acute care surgery. We said, well, this is a new protocol. I think we just need to get one because that's just what we always have been doing. So it took some time to get used to that. And then we had patients that had neurological changes, that, patients that can be intoxicated, can be difficult to examine, different nerves examined the first or last time. So where we then got a follow-up CT. So here you see the reasons, and neurosurgery was the biggest violators. And then we looked at the patients, right? So we looked at people that came back to the ED. Did we miss anyone? So you can see here, there was one patient. So people came back either for headaches, altered mental status, change in their symptoms. And then there was one patient that went on and had a referral for evacuation for chronic subdural hematomas. And lucky enough, he was actually got a follow-up CT scan, right? So the argument is that you would miss patients. This is just an aging subdural hematoma, which you wouldn't have picked up, which is not even there yet when you get your routine follow-up CT scan after 12 hours. We had a patient with one patient was admitted. So we had came in with headache, had a radiographic progression, and we just admitted her to treat her nausea, but she did not go to the operating room. And then one patient presented with an unrelated hypertensive intracranial hemorrhage. So these were, the follow-up data when we looked at our patients. So in the end, what we could, we could prevent 71% of the follow-up head CTs. This is data for 1 year. We've been doing it now for 5 years. And you need, and again, remember, we're excluding everybody on anticoagulation, and anyone that's on Plavix, but we include them as aspirin. So I think the next steps, it is a paradigm change, right? We are not used to practice. I think my team is very comfortable now. It's a multidisciplinary approach. And, I think the next step is really to get our data in the thousands to see, if there is 1 in 1,000 patients you miss, is it not cost effective anymore because you would have such a horrible outcome that would, negate all the costs you save with the follow-up CT scans. And I think there's also a lot of opportunity in big data. Are there any, you saw the parameters I used, size and anticoagulation. Are there some other parameters I'm not even aware of that maybe we can get out of big data that can tell you exactly which patient will progress to needing a surgical intervention, or which patient will need to be admitted because they're going to come back with a headache and nausea vomiting. So I will stop right there, and I think we had a good discussion. But if there's any more questions or feedback, I'm happy to take them now.
There's the only problem I see, obviously the data is the key to it, but the only problem with it is just the way that a lot of neurosurgeons, and certainly our residents and probably most of our faculty are used to practicing, is based on imaging first. And you're proposing, which is the right thing, is to examine the patient first. And that is a reversal. It's a lot easier for a resident to sit at the computer and look at 10 scans than it is for them to go visit 10 patients and make sure they're not declining. There's a big difference in labor costs there, or the cost of them having to go do this work, than it is for them to sit, and the chief can double check the scans. They don't double check the patient exam. So that's the piece of it that is potentially problematic, because what happens is you look at the scan and go, oh gosh, that scan's worse, I better go check the patient. That's what's happening. And the problem, the issue with that is that you really require, if you're not getting that scan, you really require the follow-up exam.
You're required to follow up the patient. You're required to do the exam. But I would also say there is some wrong sense of security of just relying on the scan, right? Mm-hmm. Just because you got a follow-up CT scan and it looks great doesn't mean the patient can deteriorate, an hour, slip and fall on the CT scan, right? And have, so there is some wrong sense and security of just relying on the CT scan. I tell you, I presented prior data once, and the private practice neurosurgeons came up to me and said, "What? You're getting follow-up CT scans on these people? I don't even see them."
Yeah.
Right? I'm like, "That's not new," but like, I don't even. So that we live kind of a little bit in our own bubble. But yeah, it's a huge paradigm shift. But again, we had not anybody die. Even the patients we were worried about did not progress, to even a surgery. And I think, yes, we can discuss about the 8 mm versus 11 mm subdural, or the scenario you brought up. But I think a really low-hanging fruit is the traumatic subdural hemorrhage, right? Whoever operated on a traumatic subdural hemorrhage. So I think that I think that would be, a low-hanging fruit of getting comfortable with the program and implementing it.
A very nice talk, Martina. But there are a couple of problems with implementing your particular protocol here. We can't get the emergency room to hold a patient for an hour and a half. They want the patient admitted to the hospital rather than observed in their. They won't keep a patient for that period of time unless they have a bleeding wound. So trying to get somebody to be observed for 6 hours in our emergency room is pretty much impossible. Now, it's interesting to me, this is one of the phenomenon that all of us see in neurosurgery if we live long enough, and that is that what goes around comes around. When I was a resident at Duke, we had an observation unit, and we put patients in it regularly. Many of the frequent flyers were Duke students who were drunk and fell down the stairs or something like that. And so there was a certain inurement to that process. The difficulty that created was that on one patient who was walking home from a frat party and fell and hit his head on one of the stanchions of the fence that separated the paths from the quad. He hit his head and had a red ear and was seen by an intern in our emergency room. And he was diagnosed, or the intern wrote that he had a hemotympanum, but he didn't know what hemotympanum meant. What he thought he was saying was that the patient had a red ear. They called the otolaryngologist, better than neurosurgeons, and the otolaryngologist said, give him eardrops and send him home. The difficulty was that he actually did have a hemotympanum, and he developed an epidural hematoma in the dorm room and died. And he never got a CT scan, he never got a neurosurgery consult. And that's the population that I would be most concerned about in this kind of thing.
So 2 comments. This is not so much about, we have very good guidelines who should get the CT scan, and we don't really get involved in this, right? This is the ED kind of makes this decision. I'm surprised that the ER here wants this patient's admitted, because our hospital pushed us to do this because they lost money with their admissions. And they pushed us off, and we have an ED ops unit, so they're not staying in the main ER. So it's maybe a space.
That's the COVID phenomenon. They were so slammed with COVID, the ER was.
Oh, but still, on the regular times, they don't keep patients.
I mean, think a system like this where we have 10 hospitals where we can look at scans who want to send patients in with traumatic subarachnoid, it's a perfect opportunity to observe those at those other facilities and not waste all those resources sending them.
It is, but you are relying upon the follow-up examinations by whomever.
Yeah, but that's, they're an ER doctor, that's their job, is to be able to examine a patient. You can't take responsibility for every physician.
Right, but it's the same doctor that's calling you and telling you what we hear.
Yeah, but if it's subarachnoid hemorrhage,
and
if the data shows that none of those ever need us, why are we wasting our time with it?
And I think if you have we rolled something similar out in New Mexico, and the biggest barrier was that the nurses said, well, whoa. Last neuro exam I did was in nursing school, right? I couldn't even do a GCS. I couldn't even not calculate a GCS. Don't make me do this. But now, if you have a stroke center, most nurses in the ED are very facet of doing neuro exams and doing them reliably. So also back to Dr. Maroon's point of medical legally, so I write notes, the centers want it written, that this is my decision. But yeah, I think if you can look at the scans, we have all different medical records in all different hospitals, so it's a huge headache to be able to log into all of them. But if you have that really set up, because it's a win on so many levels, right? The patient doesn't get transferred. You're not, you prevent the transfer cost. You maybe can keep these beds open for more tertiary level care. You don't overflood your ER. So as I said, we had 80% of our transfers in the ED, like the patients we saw, we just sent home, and now we are keeping them, in the outside hospitals.
So we
Hey,
did a
Martina,
study-
this is Lori Shutter. Can you hear me?
Yes, yes.
Hey, I am so sorry I couldn't be there. I had a red eye from Seattle that got in really, really late, early this morning. But anyway, I will see you this evening. I had a couple questions for you, and I may have missed this. Did you use this for all age patients or only adults?
Only adults. Yeah, in our
Only
hospital, we
adults.
only see it. Yeah. But
Okay.
I think there's the pediatric literature, I think there's actually a much more hesitancy to get follow-up scans in
Correct.
pediatrics.
Yeah.
Yeah.
Exactly. And that's what I was wondering. And then blood in head in many places equals you go on prophylactic anti-seizure medicines. Did you do that, or do you not give prophylactic anti-seizure medicines unless it's a severe TBI?
Yeah.
And
So
even
very
then,
good questions. Yeah. So very good question. I grew up here, right? And there was a blood in the head. You give the London, and then we switched to Capra. And we really, in where I work now, we re-examined. That practice because we had a lot of these elderly patients, and you give them Keppra, and the next thing they're more symptomatic from that than from what they came in on. So we are restrict that. So if you have a subdural hematoma, if you have a contusion, that's sizable, we give, but we don't. We stopped giving anti-seizure medication for simple traumatic subdural hemorrhages. So we have become a little bit less dogmatic in my practice.
Martina, this is Ian Pollack over at Children's. A wonderful talk. Just to give a pediatric perspective on how things are managed here, they actually have the opposite, almost the opposite problem, where the ER is constantly overwhelmed. And so they push us and our residents to make an initial decision within 30 minutes and to have all patients admitted or discharged within an hour, which makes the ER OBS situation, even though it sounds good, not yet practical here.
Yeah, Dr. Pollack, do you get follow-up CT scans in the pediatric population? Because I think, do you get them?
Very, very selectively. If they fit criteria that I think you had outlined, we would get them. So if there was, a small to moderate sized epidural, if it was a kid on anticoagulation, if there was a change in neurological status, then we would get a follow-up scan. On a routine basis, no.
Thank you. Yeah. So I think because there's just so much more hesitancy exposing children to radiation, they get these follow-up CT scans.
A comment on another variable. Zell, we did a retrospective study looking at spontaneous intracerebral hemorrhages in terms of which are the ones after the initial scan to change. And the two variables that we had, one was if you start with a large bleed, those are more likely to change on a second scan. But the other one, it's time from the event. So some patients come in, and if it's 5 hours, 12 hours, some patients come in 24 hours. So the later that they come after the ictus, the event, the less likely that a second scan were to change. With trauma, maybe it's a little different because the trauma happens and patients come, but some of them come in a delayed fashion. If you look at the time interval between the trauma and the first scan.
So we looked at it, so not in this study, but there have been studies written, and especially with the late epidural hematomas, right? That's what we don't want to miss. And it's the 6-hour window. So if your first scan was done, if you come in from the trauma right away and you get your first scan, so if it's less than 6 hours, there's a higher chance for missing a delayed epidural hematoma. And that's why we have, skull fractures with a small amount of blood excluded from that, because we don't want to miss the delayed epidural hematoma. But it's about the 6 hours.
another difference, because I was in Boston and here, ERs in Boston go on divert when they're full. We never go on divert here. I mean, pre-COVID, and it's the ER is more of a, you know, the opening door and everybody comes in, and I think that's just a difference in Boston and here in terms of the philosophy of what Dr. Musi was commenting.
I really do think the outlying center options helps, you know, that problem that we have with the ER and the hospital being full.
Yeah.
Something to think about.
All right. Well, thank you very much.
Thanks.